There we go.
Congratulations for the superb panel, excellent. It's just a reminder regarding the very first case you presented, that there are several residents and young people in the audience, that suspicion of malignancy is the main indication for thyroidectomy, but it's not the only one. So I strongly believe that a man, 36-year-old with a 4-centimeter nodule, probably with tracheal deviation already, is an indication for surgery regardless of any fine needle aspiration biopsy.
Any other comments or questions? While you're coming up to the podium, it was unfortunate that Dr. Nikiforov couldn't make it to this panel. I mean, he obviously was one of the big leaders in development of a lot of these markers. So,
in patients who have atypia of undetermined significance or a follicular neoplasm that you choose not to operate because of a firm analysis, I'm assuming that those patients are being followed by serial ultrasounds. At what point did you decide to operate? If you have, let's say, a 2-centimeter nodule that becomes a 2.5-centimeter nodule, are you going to operate on them at that point, or are you going to continue to follow them because of the analysis, or are you going to repeat it again?
Julie, so would you repeat the FNA if it went from 2 to 2, let's say 2.5, as he mentioned? Or I guess we should say 30% volume change, for example, or do you operate? And
well, I think that's what I was getting at, is one of the problems with all of the evidence that has been assembled is we don't have long-term follow-up data beyond, I think, 18 months is all that has been published, although I think active accrual is ongoing for 3 years. So I'm not sure I can cite a reference to say this is what one should do. You know, my observation is that, you know, surveillance is indicated, and you can't get away from needing to have the judgment of a clinician. And also, increasingly, data from Korea, I think, has demonstrated that ultrasound continues to be very useful as a tool that actually can help you discriminate malignancy from benignity. So I actually don't have a number or a percent that I, you know, live and die from, and I don't think any of us do. I think you have to assemble the demographic, clinical, ultrasonographic, and cytologic characteristics, put them into an algorithm, and come up with what you believe in your judgment is going on, and then help to counsel the patient. And I think we need to call on the GEC and molecular marker constituents and say, what happens when you follow these lesions?
Regardless of the molecular testing or what, the ATA guideline 2009 iteration is that if you have a 20% increase in volume of the thyroid nodule, that's when you repeat the fine needle aspiration.
Do you have a hard time in patients who have had an FNA that showed atypia of undetermined significance of convincing them to have another FNA to do an affirm analysis or
that is a patient choice. They have a choice to say no and have a lobectomy.
No, just in your experience, because I find that patients are reluctant. They've had, many of them have had sort of negative experiences with the needle biopsy process in the first place, that many just are unwilling to.
Given the choice of thyroid surgery versus needle biopsy, most of them are going to take a needle biopsy.
any other questions? Great, thank you again, everybody.